Are we good? Okay, all right. So let's get into supporting patients with metabolic syndrome. Again, I don't have any disclosures. So for long-term follow-up care for our post-op patients, our surgeons will typically follow up with our patients at 2 and then 6 weeks, and then every 3 months within the first year, and then after that, about every 6 months, or at least annually. They'll see the dietitian post-op at 6 weeks, and then somewhere around the 3 to 5 month mark, and then as needed or desired by the patient, or if they go to see the surgeon and they find that they're struggling with their diet or behaviors, they'll recommend that they go back to the dietitian and follow up. And our patients are never discharged. They are encouraged to follow up with us lifelong. But of course, compliance is sometimes an issue with that. We encourage our patients to attend support group. Here at Baylor, we offer support group once a month. It's virtual. This is for pre and post-op patients. We require that our pre-op patients attend support group at least once so they kind of get a feel for how it works. And then we encourage our post-op patients to continue to attend for that additional peer support. Some support group sessions are educational in nature where we discuss specific topics, and then others are more relaxed and open forum, open sharing style. Sometimes we have a guest speaker, which could be another member of the multidisciplinary team. And then sometimes we have a surgeon attend so the patients can ask questions. So sometimes we, like I said, discuss related topics and coping strategies. It's a great way for patients to meet with and hear from their peers, offer support, provide suggestions based on their own experiences. Pre-op patients will want to hear from their post-op patients to kind of get a glimpse into what it will be like after the surgery. So it's great for them to hear that. We'll talk about topics surrounding challenges in the early post-op period, focusing on adequate hydration, protein, and taking their vitamins. And then we'll also talk about challenges in the later, more long-term post-op period, such as relationships, changes at work, how to manage weight recurrence or stagnation. And then during these support groups, we like to encourage patients to highlight their non-scale victories, such as improvement in their energy, mobility, sleep, mood, strength, and reduction in their comorbidities and medications. I think these are important to highlight the non-scale victories because those are what keep motivating you to continue, because eventually the weight loss will stop, and it may not be at the point in which the patient is wanting it to stop, but we need to focus on the things that are going to continue to motivate the patient, which are those non-scale victories. We also have a private Facebook group. This is a closed group by invitation only once they enter the program. And this group is moderated by our dietitian, and it has several benefits and ways that it supports our patients because it allows for the patients to post anonymously. So we maintain a strict judgment-free environment in our private Facebook group. And so like support group, pre-op patients within the Facebook group can ask questions to their post-op peers, and then post-op patients can seek advice from other post-op patients who are kind of in the same timeline as them or those that are further out. And as mentioned before, this group is moderated, and so we maintain a safe sharing policy, but also because multiple team members have access to the Facebook group, sometimes we get a heads up on some particular patients with post-op issues that we can kind of get ahead of before they become too serious. Something that we would like to do and are planning to do in the future is to host a social event. So something like this is designed for post-op patients and their partners or family members to get together and celebrate the patients and their success. So this allows for them to get dressed up, have a night out, get together with their peers that they've met in a virtual support group so they can get together in an in-person setting, which helps them to further foster those peer support relationships. So some ideas for a social event: you could have a themed party, a gala, a fashion show where they get to get dressed up and walk the runway, have kind of a prom scenario. All of those would be very fun. An ambassador program is another way that patients could be supported. This is not something that we currently do here at Baylor, but would like to do. It's a long-term post-op patients who are motivated to provide guidance and support to others. Could be paired with new patients in order to provide one-on-one peer support. This is similar to like a buddy or a sponsor type program, and these programs have been shown to be successful in other organizations. We also have blog posts here at Baylor, which we encourage patients to look into for those that are looking for more online support. This is a great way for them to kind of read about the benefits of bariatric surgery, and they can also share posts that they find meaningful with their friends and family to kind of foster some discussion around the procedures. So we give out swag bags to our patients. This is a way to celebrate your patients who have made it through the program and they're just about to have surgery. So they've been scheduled, they're coming in for their review visit. Congratulations, you've made it. Great job, all your hard work is paid off. And this is just some gear that will be useful for them after the surgery. So, you know, it's got a typical bag, some kind of a timing device, a shaker cup for their protein shakes, and then a water bottle to help them stay hydrated. So something like this could be modeled. It doesn't have to be these exact items, but just in your program, we encourage you to find ways to congratulate your patients on making it through the program and getting ready for surgery. So the Walk from Obesity is an annual walk held by the TRIO Foundation. This is formerly known as the ASMBS Foundation. This walk is organized in an effort to raise funds for obesity research and increase public awareness, as we've discussed, and improve access to quality care and treatment. And so this is a way to encourage patients to gather for a cause, to walk with their friends and family. This year it'll be held in St. Louis, Missouri, but other satellite sites may apply to host their own walk. So any city could apply to host a walk. And so one of our goals is to host a satellite walk next year. So in summary, long-term follow-up care is critical for optimal patient outcomes, and there are many different ways to encourage patients to stay engaged and to support our pre- and post-op patients throughout the process, including the ones we discussed: support groups, chat groups, sponsorship programs, social events, encouraging them to look at our blog posts, providing them with equipment that they need, swag bags, and then just getting involved in community activities, including Walk from Obesity. And that is all. Thank you very much.
Some of the lessons that I've learned over my 22 years of running bariatric programs. And for those in the audience, whether here or virtually, who might be interested in starting a bariatric program, a comprehensive one, or rather weight loss program or metabolic program, I just wanted to give you an idea of the lessons I learned and what it takes to establish a successful, supportive program that truly helps support the patient. So, disclosure. So I don't think we need to really repeat this. We've established this, I think, quite effectively, that there is an obesity epidemic and that continues to grow at alarming rates. As most patients seek therapies, there will be increased scrutiny on outcomes, and there is. We already know that. The best outcomes result when patients have been thoroughly and comprehensively evaluated and optimized. We mentioned earlier today, just now, about how our outcomes compare with maternal childbirth, with cholecystectomy, with even appendectomy. And those results were achieved, as you might know, bariatric surgery had a checkered history. It wasn't always like this. And Dr. Holder-Haynes is going to talk just after me about the importance of accreditation. But one of the main goals of accreditation, and one of the reasons why our outcomes have improved so much, is that we take our time in evaluating and optimizing patients. And I believe strongly that this is how we, plus standardization, of course, of pathways and protocols, how we've achieved our very satisfactory results. So to achieve these superior outcomes, there needs to be essential components for any program that is being established to create a seamless and continuous multidisciplinary patient-centered program. And as I mentioned, the drivers of improved outcomes have been these multidisciplinary teams that approach the patient. They're comprehensive, they're holistic, and they allow us to improve patient selection, improve patient evaluation, improve their optimization, because we're all working together as a team, considering different perspectives from different disciplines. We standardize our operations. The days of inventing operations as we go are long dead and gone. The days of just following protocols haphazardly, they're all gone. And they're all now evidence-based. And of course, accreditation, which Dr. Holder-Haynes is going to discuss in a minute. I think the first thing to think about when a person wants to, or a group wants to start a program, is articulating the mission and values, the mission and vision of a program. And I realize this sounds a little, manufactured, but it is important to actually sit down and think about this, because this is going to be the basis for the program. So our mission here at Baylor for the Baylor program is to empower each person to improve their health, quality of life, and overall well-being through dignified, multidisciplinary, evidence-based approaches, achieving safe and sustainable outcomes. And our vision is to be the national leader and premier innovator in eradicating weight-related diseases. And it's important that not one person come up with this, but this be designed and created in a group format so that everybody participates in every word written in these statements. One thing that is absolutely critical for any bariatric program, whether it's academic or whether it's private practice, is that there needs to be administrative support. These are programs that are resource heavy. You heard us today talk about all the different personnel that are involved, the different disciplines, and I will mention the equipment and the office space. And frankly, our professional reimbursements don't really cover this. There has to be some input from other areas, preferably from hospitals, because they stand to gain so much. So these programs require initial capital and ongoing investment. They require adequate office space for our patients, equipment, and of course dedicated personnel rather than ad lib personnel who come in and fill in gaps. There has to be some kind of stability. There need to be adjuncts to help us manage these patients, especially a dedicated database for pipeline management. We're one of the few, I guess transplant are probably similar to us in that patients follow a certain pathway. as they get evaluated and optimized until they reach surgery. So we need a reliable way of tracking their progress along this pipeline, and also to improve and maximize patient retention. Because if they don't perceive that they're progressing along the pipeline, they'll just lose interest. And of course, any program nowadays needs marketing and promotional activities and resources that raise awareness of the existence of these programs. The facilities themselves have to be designed in specific ways. They have to be, of course, attractive and appealing. The furnishings and furniture have to be appropriate for our patients. The room plans have to be appropriate. And this extends not only in the office suite where you see patients, but from the entrance of the building that they come in. It has to be suitable for our patients and continues through all aspects of patient care. This includes chairs, wheelchairs, scales, gowns, blood pressure cuffs, you name it. Everything has to be procured and maintained with the patient in mind. And these arrangements should extend not only in the office suite, but also to patient rooms in the hospital, in the examination rooms, waiting areas, and of course, the operating rooms. I used to joke because when I first came here, they gave me a very small operating room. Daniel knows this. I'd keep joke that I get the biggest patients and the smallest rooms. But of course, these are just some ideas of concepts that have to be kept in mind. So these are some snapshots of our program here in the Texas Medical Center at the Jamail building. This is the entrance to our office suite, and this is the waiting area. You can see here the chairs are appropriate for our patients. They have a capacity of 900 pounds. These are the passageways and the doorways. You can see they're wide and allow patients with large wheelchairs to go in. We have a special scale that is a body composition analyzer that allows us to determine how much of the patient's weight is fat versus muscle mass versus water. And these are some of our exam rooms that have tables and exam beds that have a capacity of about 1,000 pounds. Personnel, just a brief word about that. There are essential components or essential members of the staff that are absolutely necessary, such as nurses or nurse practitioners. We obviously there's a need for a bariatric dietitian. I often say that they're the beating heart of any program. Psychologists and mental health providers and obesity medicine. And I hope today we've been able to actually, effectively illustrate in real time the necessity for all these specialists. This is not a wish list, but rather an essential need in order to be able to support our patients. If you're going to have surgery, you need the surgeons, physical medicine and rehab, anesthesiologists, preferably those who have experience in intubating patients with difficult airways and dealing with their special physiology. And as I mentioned, the pathway from new patient to surgery can be quite complicated. There are many steps that can be daunting to our patients, so they need someone who takes them by the hand, and that would be our patient navigator. And there are insurance issues, unfortunately, that we have to waste time with, but we need experts for that, and that's why we need insurance and financial administrators who are familiar with our patient population and familiar with the myriad barriers that our patients have to face. And of course, other specialists as needed. A lot of time is spent, and rightly so, in educating our patients. We found one of the keys to success is operating on a patient or working with a patient who is well-informed. And this is the true definition of informed consent. This is what this is all about. Informed consent starts from the minute the patient walks in as a new patient. The minute they receive this educational seminar that we have, we used to deliver them in person. Now they're all available online, and we ask them to attend these before they come, so they already have an idea of what we're going to talk about. Sarah mentioned the support group meetings. which are designed for both preoperative and postoperative patients. We have a number of social programs. We're going to start some cooking classes. You did not know about that, but it's true. And of course, the exercise programs and the swag bags. And these are all educational and informational resources. We also need to have, in this modern day, electronic resources for our patients. Dedicated website is not a luxury anymore. It's an essential component for the program. There has to be a reference site for patients who are seeking reliable and trustworthy information. You want them to receive the information from your website, not from Dr. Google. Adequately explains the consequences of metabolic syndrome, available therapies, and expected outcomes so they have realistic expectations. It introduces the team members. It's a nice way for the patient to understand just who is going to be involved in their care. And it is a gateway, of course, to online seminars. They can register through the website. They can submit completed forms. And in some cases, it allows direct scheduling. So what I'm trying to say here is there are electronic resources in addition to physical and personnel resources that are needed. Which brings us to social media. Sarah did a very good job touching on this. We have the Facebook, we have dedicated Twitter, the blogs, YouTube videos of surgical procedures, so that these are all information and educational resources for patients. I believe that any program, whether community-based, private-based, or academic-based, has to do an element of research. And it doesn't have to be a prospective controlled trial that requires millions of dollars to support. Any element of research is acceptable because it does drive not only innovation, but more importantly, quality improvement in any program. And I'm glad to see that this is part of our accreditation process, is that you can't get really accredited unless you demonstrate that you are continuously engaged in quality improvement projects. And the accreditation is going to be covered by Dr. Holder-Haynes, so we'll just skip on that. But I'd just like to mention that there are now about 890, maybe, almost 900 accredited programs in the United States, and that has definitely helped improve the outcomes that our patients enjoy. So in summary, comprehensive medical syndrome programs are resource-heavy programs. A strong administrative support is essential, and there has to be a commitment from them to support the program, or else it's not going to work. A rigorous culture has to be present of continuous improvement. Patient is always squarely centered in the program, and we're all just surrounding the program, supporting him or her. Patients and families should be adequately informed, educated, and supported across continuum of care. And as I mentioned, they are truly part of a family. They are never discharged, and follow-up is lifelong. Thank you very much.
Okay, so I'm going to talk a little bit about the importance of accreditation and long-term follow-up. Dr. Matar introduced some of it. I have no financial disclosures. So why is it important to be an accredited center for bariatric surgery? We've had decades of data that supports having accredited centers for bariatric surgery. It's well established that patients that perform high volume cases with standardized protocols, they have better outcomes. In addition, accreditation provides an objective and measurable means for a center to dedicate that it provides high quality care. Being accredited requires ongoing maintenance, so you have to pay close attention to detail in the care of your patients, and all accredited centers undergo periodic reviews. My data, I guess, is old. I have 700 accredited programs, but Dr. Matar corrected that we have 800 plus accredited programs in the United States. So the MBSAQIP is our accrediting body, and that was formed in 2012. And that was the result of a collaboration between the American Surgical Society, American College of Surgeons, and the ASMBS. So Baylor St. Luke's has been an accredited bariatric center of excellence, I believe, for the last 7 years. And these are some of the requirements. We have to report our case volume. We have to show evidence that we are a multidisciplinary care center. We have to be dedicated to continuous quality improvement. We have to show our protocols, and we update those as needed. And we report all of our outcomes to a national registry. There are 9 bariatric standards that we have to adhere to, and those are each further subdivided into smaller standards. In addition, we have to show evidence that our staff are trained. The hospital has the accreditation. So the staff at the hospital need to undergo obesity sensitivity training. They have to be educated on the proper methods of moving an obese patient, recognizing the signs and symptoms of bariatric surgery complications. They have to be trained in the post-op care of the bariatric patient and post-op nutrition. Those are just some examples of the training that is required to maintain our certification. So we're very proud of that. In addition, for the providers who are non-surgeons, there is an American Board of Obesity Medicine certification that you can obtain. So this provides specialized training in the care of obese patients, and it allows physicians to become medical directors if that's something that they're interested in. And all bariatric centers of excellence require a medical director. And the medical director must work in concert with the metabolic surgery director, the coordinator, clinical reviewer, and is a vital member of the metabolic surgery committee. So I think the board exam is offered, I know it's twice a year, once or twice a year. And it's well worth the training. I learned quite a bit going through the certification. So now we're going to talk about the importance of post-op follow-up. As we've stated numerous times throughout the day, obesity is a chronic disease. It's not just a lack of willpower. It's an actual disease. And like any chronic disease, like your high blood pressure or diabetes, it requires close ongoing follow-up. And as we've said before, we take a interpersonal, multidisciplinary approach, including the dietitians, the surgeons, primary care doctors, our bariatricians, and our psychologists. And this team is really important because they can help us to recognize any surgical or medical needs that our patients have post-op. And we tend to manage most what we monitor the most, right? So that follow-up is really key. And I put this last point here because even though we don't dismiss our patients and we want that relationship to be maintained long-term, the truth is that we have a hard time seeing our post-op patients, and very often our patients have an enduring relationship with their primary care doctors. So the referring doctors and our other colleagues are critical partners to us in making sure that the patients have the adequate surveillance post-op. I'm just going over covered ground here, but we know that surgery results in the improvement of many associated medical problems, but it can also lead to certain conditions, and therefore the monitoring is really important post-operatively. In the immediate post-operative period, and by immediate I mean like in the first 2 months, patients might need to have medication changes. So it's important that they see us, but it's also important that they see their primary doctor in the first couple of months. And I recommend all of my patients to make an appointment to see their PCP within the first 2 months so that they're on board, all right, so they know that the patients have had surgery and that they can make any medication changes that might be needed, such as changes to diabetes medications or weight-dependent medications like Synthroid. Sometimes our patients present with fatigue after surgery, and once we've ruled out dehydration and other causes, their blood pressure medications are often a common cause of fatigue, right? And so those medications might need to be either discontinued altogether or the dose decreased. And so that follow-up with the primary care doctor is really important. And of course, we want all of our patients, as much as possible, to be off of any NSAIDs. So we have a recommended post-op visit schedule that we try to stick to. Sometimes it's easier than others, but we like to see all of our patients in the first 2 to 3 weeks after surgery. And then the second visit is at the 6-week mark. We like to see our patients quarterly thereafter for the first year, and then once they're past that 1-year mark, we like to see them at 6-month intervals for the next 2 years, and then annually thereafter. And again, it is quite a challenge. Some of it may be related to the patients having that honeymoon period. They feel so great after surgery, and they don't see the importance of follow-up. But also some patients change insurance plans, and they just can't see us afterwards, all right? So in terms of the post-op lab monitoring, we want all of our patients to take a multivitamin of some form, and we want all of our patients to take a calcium supplement, vitamin D, and vitamin B12. We want labs 3 to 6 months after surgery, and then after 2 years, we want annual labs to be completed. We're really big on our support group, and it's a thriving, vibrant group, lots of patient input and interaction. And we reinforce this because we know that patients need that accountability and they need that sense of community, and a support group provides that so they don't feel alone, right? Our patients are at increased risk for nutritional deficiencies. 30 to 55% of patients may have an iron deficiency. 24 to 60% of patients may have a calcium or vitamin D deficiency. 24 to 70% of patients might have a vitamin B12 deficiency, and contrary to popular belief, less than 5% of patients have a thiamine deficiency. But a thiamine deficiency, if it occurs, is very serious and can be devastating for the patient. So I'm realizing now this text is too small to read, but basically it shows the dosages of the various micronutrients following bariatric surgery. So we want all of our patients to take a multivitamin that contains thiamine, B12, folate. We want them to take a separate iron supplement, separate calcium and vitamin D supplement. Their multivitamin should contain as well vitamin A, E, K, zinc, copper, and we have them take a separate calcium supplement. This table here just shows some of the monitoring that we do. So you can see that we like to get labs at least every 6 months following surgery for all of these micronutrients. Thiamine is considered optional. Vitamin A is considered optional after 2 years. And zinc is also an optional requirement, as well as copper. So for the providers in the group, this is what we expect our patients to follow. We want them to get 60 to 100 grams of protein daily. That can be in the form of actual solid food or protein shakes. We like our patients to try to get 64 ounces of fluid, and that's easier while they're on the liquid diet because everything that they take in has some fluid. But once they start that solid diet, they really get a sense of restriction, and that's where the real challenge to get the 64 ounces of fluid can come in. Something that we can't quite explain either is that some patients just don't tolerate or develop a dislike for water. Water is not supposed to have a taste, but yet patients report that it has an odd taste. So getting in fluids can really be a challenge, and so sometimes we recommend that they change the temperature or add flavoring to their water so that they can get enough. We recommend that our patients avoid high sugar and high fat foods. On average, we try to encourage 1,200 to 1,500 calories per day, but that depends on their activity level. And then, of course, regular activity is key. Those are our post-op recommendations, and we'll have our panel now, and we'll take any questions that you have.
Thank you. I do have a couple questions. The first one is for Sarah. Thank you for going through all the different resources that we offer to patients. I was curious because you mentioned the Walk from Obesity. Are we planning to participate in the ASMBS one this year? And do you have the information on that to share with people?
Yeah, so it's in St. Louis, Missouri. We had discussed possibly doing a satellite host this year. However, we are up for accreditation. I know it's in August, so I'm not sure we're going to apply to host this year, but we will next year.
Is that the same one as the ASMBS? Because that's usually
Yes.
in the fall.
Yes.
Yes, and yeah, we're skipping on it this year. However, we will explore, we'll research and see if there are other programs in the area that are actually hosting it, and then if so, we will join them.
Yeah. So we may not host, but we can still participate.
But the act of hosting takes a lot of effort at this time.
Dr. Matar, sorry, this is my second question. Can you comment on what features and characteristics would make a bariatric program successful after it's been established, like in the long term?
Well, I mean, you have to remain true to your mission and your vision. That's why I thought it was very important to establish that as a first case. And by that, I mean everything that comes with it. So if your main interest continues to be to provide patients with safe, superior outcomes, then you have to continue to work towards doing that in a form of continuous improvement, keep strengthening support from administration, make sure the staff are updated on recent developments and research and advancements in the field, and keep exploring ways on how we can better inform, engage, and improve patient retention, because it's been shown that's the most effective way of preventing weight recurrence. Sharon.
Only thing I wanted to say was that last year there was a virtual walk, so we participated in it. We probably could have done a better job, so maybe this year we can plan ahead and do more of a virtual walk. That's what they had suggested last year.
So let me repeat what you said, because your microphone was off for our virtual audience. Ms. Galloway mentioned that last year we participated in a virtual walk, and whether we were going to do that again, is that right?
Yes.
Yeah, I don't think there are any virtual walks planned for this round, are there?
I'm not sure.
Yeah,
Yeah, I'm not sure.
but we'll look
That's a
into
great
that.
idea. Thank you, Sharon.
Yeah. Done.
Dr. Matar, this is for you. In regard to the statement that you mentioned earlier in regard to the vision of becoming a leader in metabolic practice and in bariatric surgery, of course, we know this space is ever growing. It's getting more and more popular to an extent. And then also there's just more visibility, more interest from patients as well as surgeons just in general. How do you maintain not even competitiveness, but more so
Edge.
Yeah, that competitive edge, considering it's ever growing.
Well, it's really, I don't think we should look at it as a competition in say, the volume of patients that we see. I'd rather see us in competition on how to achieve better outcomes. And I think if we continue to demonstrate that our methods are resulting in better outcomes, then the patients will come.
But also, patients refer their friends and family as well, and so that's how we've been able to see a lot of growth.
Word of mouth is very important, yeah. Dr. Leip.
Yes, and this is for you as well, sir. What advice would you have to patients with the most recent increase in weight loss clinics? Um, you can walk anywhere and get somebody just prescribing,
Thank you.
Mounjaro for a much lower price and
Yeah,
without having a plan set up. And I
right.
know these are becoming more and more common. So, from a patient perspective, what's the best way to approach those?
Well, Dr. Leip, you answered your own question a little earlier. I clearly heard you say that patients need to do their research. And there's nothing wrong with visiting 2 or 3 centers or programs, a mix of surgery centers or comprehensive centers or weight loss clinics, gather information, ask friends, ask relatives, find out about the programs, about the reputation, meet with the providers. There's nothing urgent about this. There is a sense of urgency, but in reality, it's not urgent. Take your time, and once you feel convinced that one program is better than the rest, then go with that. I'd like to thank all our speakers, all our moderators, especially Dr. Leip for coming and donating her Saturday to us.